Good afternoon. And today we have an honor to interview Dr. Dania Tamimi. She's my colleague. She's a dentist, but she has a very unique specialty. She's a dental radiologist and author of many books. Good afternoon, Dania.
Hi, how are you?
And thank you very much to our audience. And if you have trouble sleeping or sleep next to the snoring partner and you want to know a little bit more about that intricate way how we provide the treatment, yes, we use dental radiology when we do the examination, comprehensive evaluation of patients. And we use the help of a dental radiologist like Dr. Tamimi. And if you're a medical professional who want to um, understand kind of unique light what we as dentists uh, use to diagnose and treat our patients, please listen to our channel and use it as a networking ground. This way, connecting with other medical professionals who are passionate about sleep and breathing, together we can find all missing puzzles of that dangerous disease. So again, I would like to introduce our guest, Dr. Dania Tamimi. Actually, we met at an American Academy of Dental Sleep Medicine conference, and I was so impressed with the book. And doctor, if you can show us your book. I interview a lot of authors, but as I mentioned many times, I never have anybody who wrote such a big book. Yes, and it's not only one and not two, it's more than 3 books, and you can find them on Amazon. They are really comprehensive. And they about dental implants and about temporomandibular joint and temporomandibular joint in related to sleep and oral maxillofacial surgery. So those are a great, smart, comprehensive books. And I want to tell a little story about Dr. Tamimi. So she graduated with dental degree from University, King Saud University in Riyadh, Saudi Arabia. And then she trained in Harvard School of Dental Medicine and earned her doctorate in medical science. And she has fellowship in oral maxillofacial radiology in 2005. And she's a board certified dental oral maxillofacial radiologist. And she's on review and editorial board of most of our specialty magazines. Um, and as I mentioned, she writes those beautiful books. And also, in addition to that, she has her private practice where she look at the X-rays or 3D X-rays all day long. So now we're going to delve into that little deeper. And I would like to ask you the first question with a very sexy word called AI. So now, like, everything is about artificial intelligence. Please tell us, with advancement in artificial intelligence, can AI effectively read and analyze 3D dental images? And what are limitations, according to your professional opinion, what AI ability to interpret such images accurately?
Hi. So it definitely has a lot of promise. So we do see it being used in diagnostic radiology for CT, MRI for the detection of minute lesions that may be missed by the radiologist, and but it's used as an aid. So it's not asked to do the work on its own. It has to be supplemented with a human looking at the images and also rendering a human opinion. Okay. In the world of dental radiology, we do have AI also helping us look at plain film imaging for any things that are minutely different that may indicate the presence of pathology. And recently, there have been several software that have been developed for the evaluation of cone beam CT, which is the three-dimensional radiographic imaging that we currently use in dentistry. The thing is that there's still a lot of work that needs to be done. The software is not as intelligent to determine whether something is artifact versus a true finding. And then also when it comes to the complexity of the craniofacial complex and the growth and effect that happens with the breakdown of one part of the craniofacial complex, with the jaws, with the TMJ, with the airway. All this stuff is related to one another. So AI still hasn't been taught to figure those things out, how one part of the dysfunction of one part of the head or the face or the jaws can't affect the rest. Okay, so maybe it's coming in the future, but currently I still have a job.
That's very promising. That's like, this is a very unique specialty for me. So I mentioned we met in the American Academy of Dental Sleep Medicine, and it was always a question for me. I would say, it was a lot of significant events in my life that opened my eyes. Like I would say, coming to United States, or the same way when I discovered myofunctional therapy. But third thing was 3D X-ray. I have 3D X-ray in my office, and I cannot thank enough for having such a technology. It's been in my practice for 3 years, and I've been practicing since 1994. So I always use two-dimensional. And now what I can see and how I can make connections based on my clinical experience, seeing what I see on the X-ray, it's really, eye-opening. But it was always a question. And I know the same question really, hot topic of a lot of dentist conversation about interpretation with radiologists. And please tell me, what expertise does radiologist bring to diagnosis and treatment planning process? Different what other dental professionals, including myself, can have. Because, if you practice, you think you know it all. So that's not true. But what's your methodology and what you bring to the table?
Well, first thing, if your eyes will only see what your mind knows. Okay, so when you open up a cone beam CT scan, a 3D scan, and you look at it, what your eyes are going to pick up is basically a summary of your own knowledge. So the more knowledge that you acquire, the more that you're going to see. Okay, and when it comes to the evaluation of this complex, it's called the craniofacial complex for a reason. It is a very complex structure. The head and neck area, the different bones, the teeth, all the stuff is very complex, and there are a lot of moving parts, no pun intended. And everything is three-dimensional. So when we look at this craniofacial complex in 2D, it's like you're squishing everything. Okay, so you're not getting the full picture, whereas 3D just expands everything and gives you the ability to spin things around and look at them. Okay, the thing is that because it is so complex, it does require more education. Okay, and in my specialty, it's a minimum of 2 to 3 years of extra education. It is a dental specialty that's recognized by the American Dental Association for a reason, because it requires all that extra knowledge to be able to perform this procedure. Now, a dentist like you or anyone else can also acquire this knowledge, but remember that the more you know, the more you will see. And then if you don't continue your education in imaging, like I do, as well as my education in all the dental specialties and the medical specialties that have to do with the head and neck, like ENT, head and neck surgery, cervical spine, orthopedic surgery. That's where my education is. Okay, because I'm helping you look at all these things and understand how they relate to your patient, your three-dimensional patient. Okay.
No, that's a great answer. So I want to mention about another topic what we discussed with Dr. Tamimi about the courses she's offering for dentists to get a better vision. The courses to read the 3D X-rays better. And you can find the link to those courses under this interview. And I hope you can increase the level of your knowledge with Dr. Tamimi expertise and guidance. So I would like to ask you also what opened my eyes. I start seeing degenerative joint disease, and I interviewed several people, including orthodontist Dr. Gellerman, who used 3D X-ray from 2006. She said, there are so many degenerative joint disease now. Can you please shed the light? What factors contributing to this increase and how dental radiology play roles in diagnosis and management?
Okay, so understanding this, why there's more of this being seen, has you have to understand the continuum that leads to degenerative joint disease. Well, first of all, when we were looking at our panos and our 2D cephs, we couldn't really see and evaluate the condyles with great accuracy like we can with 3D imaging, because it's a three-dimensional structure, and when you look at it on 3D, you can spin it around, you can look and see if there are any minute changes. Okay, back when we were doing 2D panoramic and lateral cephs and frontal cephs, we couldn't really form a good diagnosis. So that's one thing that may lead to the assumption that there is more degenerative joint disease. But now, the understanding of the continuum of degenerative joint disease. The degenerative joint disease, what we as dentists or in general, when we think about it, we think about sclerosis, a lot of bone becoming very, very dense, osteophyte formation. These are the end stage of a process, and that process is a biomechanical failure of the joint. Okay, the joint is made out of soft tissue and hard tissue, and the hard tissue doesn't fail unless the soft tissue fails. Okay, now what makes the soft tissue fails? Okay, the soft tissue being the disc. Okay, so when you think about a clicking and popping joint, what is that? It's a disc displacement, and the disc displacement is a result of a breakdown of the structure of the disc, the collagen fibers and other structures there, and they break down because of increased biomechanical loading. So now you're going to ask me, what's increasing this biomechanical loading? I'm going to tell you that a big portion of it is our clenching, bruxing habits. So tell me, what makes you clench? Stress, right? Okay, so you're stressed. Or there's like some interference with your teeth, or you're like, ugh. Okay, so that stress, that increased stress, the increased clenching will precipitate a biomechanical failure of the soft tissue, which with time will precipitate a biomechanical failure of the hard tissue, which is the degenerative joint disease that you and I see and know. Okay, so yeah, so that's it. So just understanding this, and of course, look around you. Who isn't stressed? Everybody's stressed. COVID, there was an uptick in TMJ pain with COVID because of the stress that everybody was under. So,
on our last week's interview, a couple of weeks ago, we interviewed Dr. Jamison Spencer, who talked about 1% of occlusion. So we're supposed to stay with the teeth together only 1% of the time. But
Yep.
That's not the case, and we're trying to catch the time, and it's a very stressful process, I think. Osteoarthritis, that's the result. Now I want to ask you that question what AI cannot answer. What's the connection between occlusion and sleep disorder breathing? And you have a whole book kind of devoted to that. And could you please explain the relationship and how dental imaging can assist in understanding and addressing that connection? Like, I really like how you talk about stages of that, but it's not like today you wake up and, this pain and and sleep is not restorative. What exactly happened?
And of course, I'm making it very simple because we only have a few minutes together, okay? So when you say occlusion and sleep disordered breathing, it's really about the TMJ and occlusion and sleep disordered breathing and the airway and the entire craniofacial complex and how it forms, ever since someone is a child, a baby, and a child, and then adolescence through adulthood, and how when a joint or the airway falls into dysfunction, it will change the morphology, the shape of the face, and change the function of other components as well. Okay, so I'm going to keep it simple because of the time. All right, so you asked me a specific question about the occlusion and the airway. So occlusion is how your teeth come together, okay? And we all know that when we open our mouth, our teeth come apart, right? Okay, so one of the instances that we would normally have our teeth apart, our mouth open for a long period of time is if your nose is blocked. Okay, so if your nose is blocked because of sinusitis, because of a deviated septum or something like this, you're going to have to resort to open your mouth. Okay, so when you open your mouth, you now are moving the teeth apart. And we all know as dentists that teeth will constantly try to super erupt to touch each other. Okay, so when we look at the teeth in the arc and how they fit, the first teeth that are going to touch are going to be the back teeth. So what's going to result is an open bite in the front. And eventually, if nothing is done about it, then those teeth are going to all come together, with that, with that steepening of the occlusal plane. Okay. Now, another way that our occlusion is related to airway is that we could also move our mandible forward, okay, our lower jaw forward, to take the tongue out of the airway. Okay, and the tongue is attached to the mandible, attached to the lower jaw, and that is going to, if the jaw is small and posteriorly positioned, then the tongue is going to be posteriorly positioned in many cases. So one of the ways that we, as humans, especially children who have really large palatine tonsils layer, they need to take the tongue out to increase the dimensions of their mouth, their oropharynx, their airway. So when they do that and they hold their mandible forward like this, the teeth are going to super erupt, and the teeth super erupt and they contact one another. But the problem is now in this forward position, the condyle moves forward and it's now stuck in this position that is forward. And that is not a biomechanically sound situation for it. So it precipitates a whole bunch of changes in the soft tissue and then the hard tissues, just like I just talked about, Okay, that's it.
So this is such a complicated system. And that leads to my next question. What are some common misconceptions what medical doctors have about dentists? And what did you experience in those interactions? Because one of the reasons for this channel, and I created to create a connection between medical and dental community. But it seems like medicine built this little house and we have our own dance and we don't dance together. But you actually on the verge of these two specialties, I would say. Yeah. And what do you see?
Well, let me start by saying, one of my professional goals from the very beginning was to bridge the gap between dentistry and medicine through my field, through my craft. And it started when I actually went to a medical conference, a medical radiology conference, and the medical radiologist there was teaching people about the oral cavity. And he said, I'm going to now show you how to name the teeth. Are you ready, everybody? And he said, the medial incisor, the lateral incisor, and for the lay people here who are not dentists, that's your teeth that are in the center, the front teeth are called the central incisors. Okay. So that's like, there's nothing called the medial incisor, so they're just propagating this misinformation. It doesn't just, it's not just limited to the names of the teeth, but also many concepts, everything to them. I mean, they've got 3 lesions as pertain to the jaws, and only these 3 lesions, they remember, and differential diagnosis 1, 2, 3. They don't have that complexity that is necessary for the understanding of dental disease. Okay, so I'm not saying, of course, they're great at what they do, but the reality is we're subspecialized in this, and we, as a dentist, myself, I practice dentistry, so I have an understanding of how dental disease occurs, whether it's inflammatory or pathologic, other neoplastic or cystic. And in order to evaluate the craniofacial complex or the jaws in particular, you have to have that understanding of the progression of dental disease. Now, one of the things that you're saying, what are the misconceptions? They think that it's all about the teeth. So what do you do as a dental radiologist? I've heard that so many times. What do you do as a dental radiologist? I'm a physician, just like you, and I deal with the oral cavity and the things that are connected to it, like the jaws, the TMJ, the airway, to the shape of the face, the neck, and how that is functional. See, when a medical radiologist looks at scans, it's usually anatomic. They're not thinking about function. Okay, they're not thinking about this. If this happens, what's happening downstream of it? It's like there's this lesion. Let's characterize it. Let's look at it. Whatever. But we have a little bit more of complexity in thinking because we're thinking over time. We're thinking this is happening here. What's going to happen in the future because of this? Or this has happened here. What has happened in the past? There's a lot of that in dentistry, as you know. So anyway.
No, but it's a beautiful way. Now I'm going to ask you the question, what bothers me for a long time, and I really like as an answer, what we discussed prior to this interview, you brought the scientific literature related to interpretation, to my previous question, interpretation of 3D images. How frequently do you encounter plaque or thrombosis in carotid artery? Because, inside of us dentists, inside of us, we really think of ourselves as a big hero. We can save people's lives. And a lot of times we do. Like with the meticulous work, with the periodontal disease, with the sleep and breathing, now dental sleep medicine. But in your field, you also can feel yourself as a hero by saving somebody's life, diagnosing the calcification of carotid artery. How often do you encounter that? And what literature said about that? And what role dental radiology play in addressing those issues?
Okay, so of course there are multiple other things I can diagnose, not just the calcified atheromas. Okay, so let me explain for the lay people, because I know that some of your viewers are not medical. All right, so basically what we have, everybody here has heard of atherosclerosis. Everybody here has heard of atherosclerotic plaques and what it can do and how it can precipitate a stroke. So basically, when you have an atherosclerotic plaque in your arteries, it tends to occur in a place where there is excessive turbulence. Okay, and the places that are most turbulent in the head and neck are going to be what's called the carotid bulb, which is right here. So it's on our scans as dentists, even the 2D scans. Okay, and also intracranially inside the brain, in a place close to what's called the cavernous sinus. Okay, so it's the internal carotid artery and how it twists and turns in that particular area. Okay, so these are the areas that I look at every single time I go through a scan, even though I can't see the hard tissue, the soft tissue rather. I can't make out the actual carotid artery, but if there's a calcification in that artery, I can see it. Now, what does that calcification mean? Okay, the calcification is basically that plaque that has accumulated there, okay, that may or may not be closing off the lumen or the channel. Okay. All right, yeah. It has now reached a point of quiescence, so it's not an active plaque. And what the body does with things that are not active, it tends to calcify these. Okay, so when I see these calcified plaques, it's telling me that the patient has some sort of cardiovascular disease that has precipitated the presence of the atherosclerosis, and that at this point we have this calcification, which may mean that it's no longer active. Okay, doesn't mean that there isn't more of a blockage that is soft tissue. I can't tell that, but at least I can identify this, and then I can say, go to your doctor, get a ultrasound, Doppler ultrasound of the neck, see what else needs to be done to determine whether you're getting enough blood supply to your brain. If it's blocked, obviously there's an issue, right? So that's one thing. So now what's the incidence of this? This is going to happen in adults. So depending on how many adult patients you see, like orthodontists tend to see a lot of younger patients, adolescents. If you're seeing a lot of older patients, the current literature says about 30% of individuals will have carotid calcifications that are visible on cone beam CT. Okay, and of course the numbers go up and down depending on the study and the location and the sample that they use, the number, like the age of the group that they use. But in general, and that's 30% would be 30% of people who are of a more like middle age and above will have these calcifications, you know, and that's very similar to what I would see within my adult population.
So thank you very much. This is
Yeah.
like eye-opening. So we can become a hero and save somebody's life with the help of dental radiologists. And again, I want to mention again about the courses. What you're doing in a book you wrote, eye-opening, just like 3D scan. And I highly recommend to our listeners to check the courses and read the books. And again, Dr. Tamimi, thank you very much for these wonderful answers, and I learned a lot. And I think it's encouraging to send X-rays for interpretation to dental radiologists to be able to see what we don't see. Thank you.
Yes, thank you so much for your time, and hope to hear from you soon.